Welcome and benvenuti a tutti to the inaugural webinar of the Italian chapter of SSAT. This webinar is another stepping stone in the effort of SSAT to reach out to our colleagues in Italy and worldwide. The goal of SSAT Global Outreach is to improve the care of patients with GI diseases through education, innovation, academic excellence in GI surgery around the world. Italy has a particular record of tremendous contributions to SSAT with past board members from Italy and its long tradition of high quality scientific contribution at our annual meeting. Please join the SSAT. Encourage your colleagues to join. The benefits of SSAT membership include a free subscription to JOGS, access to high quality webinars, and travel grants. We have set aside funds for each chapter, and I hope you will take advantage of this to grow your chapter. SSAT is very grateful to Dr. Torzilli, President of the Italian chapter, and to his colleagues, Dr. Pietrabassa, and also Dr. Del Fabro and Dr. Donadon for their hard work to build this chapter. The symposium will be led by 4 moderators, 2 moderators from the US, Professor Weber from the University of Wisconsin, and Professor Patty, who has a long experience with education in surgery. Now we'll let Dr. Torzilli introduce the Italian chapter and introduce Professor Castoro and Professor Falconi. I wish we were here in Milano and we could visit the Duomo and be all at the top of the Duomo, but we'll be to these heights another time. In the meantime, we'll elevate the Italian chapter of the SSAT. Welcome all.
Thank you very much, Dr. Votei. It's really a privilege and an honor to be in charge of support the idea of the Italian chapter of the SSAT. Your generous and very kind presentation of our community has been a privilege for us and a source of pride, and we have to show, and I hope we will confirm all the attention that you pay to our community, that SSAT is paying to our community, not disappointing the mother society of to which we belong. Now we have quite almost 50 members, SSAT members. Someone are now just newly registered in the community. And then we will try to sensitize our community to enter in an inclusive society as your society and our society now is. And we have, as you said, the possibility of having also a journal to which refer our products, which is Journal of Gastrointestinal Surgery. We have the appointment every year of the big meeting, the SSAT meeting in the DDW meeting. This year will be in May in San Diego. And then it's really a challenge, but I'm sure that our community will not disappoint the expectancies of the society. So we will, as Dr. Votei said, run this webinar with 2 moderators from the US and 2 from Italy. And it's my privilege to present, to introduce Professor Massimo Falconi. Is a worldwide renowned expert in pancreatic surgery and is running his department of pancreatic surgery at Ospedale San Raffaele and Vita and Salute University. And the other co-moderator from the Italian side is Professor Carlo Castoro, as a renowned esophagogastric surgeon who is working in the same hospital where I am, and is also a full professor of surgery at the Humanitas University, to which I belong together with Professor Spinelli and Professor Donadon. That's it. I think that we can leave the moderators to start the session, if Dr. Volotei agrees.
Guido, it's a great honor for me to be invited in this first initiative on residency educational program, and I think that my co-moderator could run and present the first speaker. Please.
So, also from my side, thank you very much for inviting me to co-chair this webinar. Thank you, Professor Botte, and thank you, Guido, for the hard work you are doing for the Italian chapter of SSIT. So it's a privilege to introduce the first speaker. Guido Torzilli will address possibly the most important topic of the day. Everything will go around this topic. So he will give an overview on the current programs in surgery in Italy. Please, Guido.
Let me share the screen. Okay. Well, it's okay. Why not? Okay. Let's start my talk. Again, thank you very much for the invitation. So I am auto-invited person. Anyhow, residency programs in general surgery in Italy, challenges and obstacles. We may say that the argument is quite general, and I would like to follow this agenda. We will start with the principle that should animate a residency program, and based on the first dictate by Sir Alsted, see one, do one, teach one. This insight nowadays is a little bit evolved towards something more complex, which include the control, the trust of the resident, to let the resident the autonomy and being charged of the responsibility of this special work as it is the one of the surgeon. And the surgical trust depends, of course, of an interaction between the tutor and the resident, the pupil, perceive the risk of the case, because of course in the mid there is the patient, who is the most important actor of this triad, the perceived trustworthiness of the residents, and then initiation to trust, observation of the steps, preliminary, and then after decision, looking at the progression of the resident, the intervention, and at the end, resize the trust accordingly. And this process proceed in an increment of the entrustment and the belowing the control, observe, directly supervise, indirectly supervise, and no supervision, then autonomy. At the end, similarly, also this paper is stressing the same concept: teach, do, and assist, supervise, entrustment increase progressively. This kind of method is quite safe. These two reports show that there was no decrement of the safety of the procedure, including and involving the resident in the process of, in the clinical activity. The environment, and then let's enter in the Italian system. The environment of the Italian system is a changing environment as a history, not always easy to be understood. We have 41 residency programs spread out the country. 5 years length is the residency program. The selection is based on a national multiple choice test, 140 questions on medical issues. And the leadership, which is under attack, I may say politically, of the residency program is academic, despite, of course, there are tutors coming from the branching hospital. Where the residency program are maybe, I may say, equally distributed around the country. We have 21 regions, and the region with more residency program is Lombardy. It's the richest one. Where I'm talking is exactly from Milano. We have 7 residency programs, but if we divide the country in 4 parts: North, Center, South, and Highland. The distribution is quite homogeneous, despite the appearance. Anyway, we have 7 programs in the South, 5 in the Highland, 14 in the North, and 11 in the Center. The higher rate of population is concentrated in the North, which is the most industrial and financial part of the country. We have observed in the years almost from 2018 to 2021, doubling the number of positions available for the applicants in the residency program all over the country. From 371, now we are 801 positions. The pandemic has played a role. I mean, the COVID, say something good, and stimulate the European Union to help all the countries, which was a big support for us. And nowadays, the residents has a lot of position waiting for them at the end of the program. Then we have incremented the position to fulfill the request of surgeon as for any other. The drawbacks of the system, well, we have to observe, but this is possibly a phenomenon that is happening all over the world. Back surgery is in Italy, the 22nd residency program according to the applicants' preferences. The students prefer to follow ophthalmology, plastic surgery, cardiology, internal medicine even, and even because now we have a lack of internal medicine doctors. And this is a good news, but also dermatologists and whatever. Surgery, I mean, is not so popular. And if we look at the possible lack of vocations that we can find, is the low income, possibly, at least in Italy for sure, initially, and possibly also in the future. Hard work, because it demands a lot of activities, high responsibility, and difficult progression, biased by several professional and non-professional factors, unfortunately. The drawbacks, also the program is possibly too short, but this is not for the vocation, is on the side of the educational process. In my idea, and so most of my colleagues think like that, is too short. 5 years is not enough. We have no, especially because we have no fellowship program established. We are trying to, and there is no homogeneous training path. Of course, there are a lot of rules, but at the end, any school tries to provide its own idea. And also, officially there could be, but there is no failure. You generally do not reject, we promote all the residents. And at the end, with the increment of position, the school adequacy become a critical point, because some are old-fashioned. This is a noble school, but I mean, for sure, not sized for the applicants to provide enough facilities to support the educational process. The idea, we are one of the youngest university, was founded in 2014, and the second youngest residency program. It was up to last year the youngest. Now there is a new residency program this year. And in the sparring background, I was in charge of organizing this school, and actually still the director. Is based on, of course, of my personal experience. I had the chance, and my And it was the chance that happened to many Italians to migrate to elsewhere to get educated and to find the right way. And for me was Japan, Makuchi, training, assisting me, but initially, of course, I was assisting a lot him, and the mentorship. Then this example has inspired all the construction of the path that I am describing, the achievement, the strong basic background, the basic knowledge of satellite disciplines, subspecialties overview, allow deepening in the preferred subspecialty, facilitate experience abroad in the preferred subspecialty. These are the targets, and the modality that we have built based on the headquarters is the University Hospital Polyclinic Cancer Center. We have a department of surgery, which I am leading, is with hepatobiliary, soft tissue and sarcoma, general surgery, esophagogastric, pancreatic surgery, colorectal surgery, and emergency surgery. And me, Professor Montorsi, Professor Quagliolo, Professor Castoro, Professor Zerbi, Professor Spinelli, and Dr. Del Fabbro are those who are running this program. We have also facilities like a simulation center, which is nice. We have a robot and several simulators, 24/24, always available for the residents. The network, of course, is fundamental to allow the path running well. We have 3 branching hospitals other than our hospital, and they have a schedule since the start of the school, well fixed. General surgery, emergency surgery, generally mid-low complexity in the first 2 years, interventional radiology, endocrine surgery, ultrasound, urology, bariatric surgery, ICU. They have to understand which is the panorama, to have also the right to select which will be their own path after the residency program is ended. The 3rd and 4th years are spent in the high complexity surgery, hepatobiliary surgery, colorectal advanced surgery, vascular surgery, thoracic surgery, pancreatic, upper GI, sarcomas. And at the end, the period abroad, according to the subspecialty that freedomly the resident will select based on the previous 4 years and the experience that he had in the previous group. We would like to establish a fellowship program. We already have a PhD program for those who are interested to the getting deeper in the research activity. The measure, which is an important aspect, is the concern. You know, we have to lead to the autonomy. We are not living in an easy environment. Residents are perceived as can someone stop their own microphone, because there is a printer that is working. Anyway, residents are perceived as students rather than doctors, which is a problem. This is a paper on an article on the Corriere della Sera and on this issue. And path of autonomy has to be secured from litigation. Given this background, rigorous process and adequate communication with patient and community are indispensable for that. We have developed a path to autonomy, which has been endorsed by the Regione Lombardia, the area in which we are working, by all the residency program who are working here. In outpatient, inpatient, emergency room, we have a graduated exposure of the resident in terms of assist, cooperate, and leadership at the end of his own path, and also for the operation, complexity, low, medium, high, and of course the involvement of the resident is graduated in the role that they have to assume during the courses. Surprisingly, I saw that in this paper, an example, the outcome and complication is not perceived as a strong element for assessing responsibility. I think that we are building our path exactly on that. Surgical reports has to be divided in specific phases to be recognized with the main actor, and then link the surgical report and the database, I mean the outcome, with the role of the residents, and then measuring their own the outcome according to their own activity in a traffic light progression to certify the autonomy, the red light, the yellow light, and at the end the green light. Theoretically, we should get, once you have the green light, even though during the course you can be certified to be autonomous in that area of the activity. And then we move to the conclusion. In this year, with this kind of modality, we have encountered the preference of many applicants, and now we are ranked as the first program in our country. And I might say, for disclosure, that the other one is the one that is in which Professor Falconi is working, is the San Raffaele Hospital Eder in Milano. Then I hope, concluding, that the image of the resident I had when I was young and I had to migrate, the retractor holder, will disappear soon with this logic. And I'm sure that nowadays we are providing skilled surgery for our community and whatever. This is the best way to thank you and to say hello. Is the picture of my first, or the first resident that we have released last year after the first condition. We look at the future optimistically. Thank you very much for the attention.
Carlo, would you like to comment?
Yes, thank you. Thank you very much, Guido, for this very, very nice overview of the current situation, both in Italy and the Humanitas University. If I remember well, we will have some time for the discussion at the end of the session. So I think we can write down our questions for you to, and reserve them for the discussion later on, if you agree. Is that okay for you all? Okay, so I'm now leave the stage to Massimo Falconi for the introduction of the next speaker. Thank you.
Carlo, thank you very much. I would like to excuse ourselves because we forgot the role of our colleagues from United States. So it's a great pleasure to ask both Professor Marco Patti and Professor Sharon Weber to give us their perspective of this webinar. And thereafter, we are moving to the second talk by Dr. Antonino Spinelli. Please, Sharon, since you are a lady, I think that gender now is not really an issue in this seminar. And could you give us your perspective from the other side of the ocean, please?
Yeah, I would just really welcome the group, thank our president, Dr. Vote, for his vision in starting these global outreach sessions. I think it's been really instrumental to the SSAT to include new international members. And I know everyone has put a huge amount of work into making this happen, and I thank you very deeply for that. I also think this has been a very successful effort for us. In a very short period of time, we've had 5 of these webinars so far, including Mexico, Japan, Kuwait. And so we're just delighted to welcome all of you to the SSAT. So thank you for having us.
Thank you, Sharon. And sorry, Marco, could you give us your perspective as Italian and one of the best surgeons in the United States?
Thank you very much. I agree entirely with Sharon about what Dr. Vote has done for the SSAT. I just want to remind you that I'm Italian and I train in Italy. And the reason I left was for the incredible poor quality of training in Italy. That's why I went to the United States. I was lucky to train at UCSF in California. I thought that the talk of Dr. Torzilli was beautiful. There is no question that the Humanitas is a leader in Italy, but it does not represent at all the average training in Italy. As he stressed, there is a major difference between the North, the Center, and the South. So my hope is that under the guide of dedicated academic surgeons like Dr. Torzilli, the other members of the Humanitas, other programs in other parts of Italy will be able to move towards an homogeneous path where residents are really trained. So I can only congratulate him for what he has done at Humanitas. Regarding the experience abroad for subspecialties after they finish residency, I think is important, but you have to be very careful. If you don't pass the required examinations and you have a license, you can do research, but you cannot touch a patient. So again, I suggest that maybe if you identify brilliant residents during their training, they should study English and they should study to pass the so-called, the ECFMG, that is step 1, 2, and 3, and then eventually spend 1 or 2 years abroad. I think Dr. Spolverato has experienced, because if I recall, she was at Johns Hopkins, and she works with Tim Pollack, who is now the chair of surgery at Ohio State. So again, congratulations, with the hope that the rest of Italy can follow the example set by the Humanitas.
Thank you, Marco, also because you are really a beautiful example of what was in the past and what is today, and from Italian and both from United States perspective. Sorry if I'm teasing you. You did a great mistakes. In Humanitas, they did a wonderful job, but they are still second. And after San Raffaele Hospital, but this is just a joke. It's a great pleasure from my side to introduce one of leading professor, full professor in surgery, once again in Humanitas, which really expresses one of the best school in residency. And this guy is Professor Antonino Spinelli, who is also one of the youngest full professor of surgery in Italy, as you can see from his images. Please, Antonino, would you like to give your talk?
So first, I would like to thank you, Massimo, and I would like to thank Professor Torzilli and Professor Voté and all of SSAT for organizing this incredible webinar that I think it's extremely timely and extremely important. So how does the minimally invasivity change the residency program, if it does? So if you look at that guy indicated by the arrow, probably what he was seeing from that operation was not a lot. And probably this is one of the main points why many people regard it as at the onset of minimally invasive surgery as one of the most impactful revolutions, also in terms of surgical training. So it's not enough to leave somebody in a field that has some fertility to expect him or her to grow as a surgeon. And education is definitely, especially or even more when it is related with also some technological skills and tools, time-consuming, costly, and definitely still exposed to some restricted expertise when it goes to some types of surgery. And this is definitely not related only with minimally invasive surgery, but also if you go for subspecialization in general surgery. And even more, there have been a lot of challenges generated by the COVID pandemic. But there are some opportunities that are related with minimally invasive surgery itself, and these are related with the boost of technology, with the improved and magnified vision, but also to think that the trainee and the spectator had the same vision as the first operator. This is not without it's not basic, because you have to imagine that the retractor holder that was mentioned by Professor Terzilli is actually a character that is still there in many situations. So furthermore, minimal invasivity and video recording and video uptake and storage also was important, because the procedures, once you look at those, are always more comparable. Why? Because you get the same vision from one procedure to the other, because the trocars are basically related, put in the same way, or a very similar way in most of the cases. The procedure are easier to record, store, and be subdivided and tagged, which is important when you have to learn a procedure and you have to subdivide it and learn each step in a kind of independent, as an independent step, and which is also related with what Guido said about the fact that the resident should learn and should be credited for accomplishing a step of the procedure itself. And then furthermore, there is a lot of help from the digitalization of the videos, and we will see this soon. So are the videos the new books for general surgery residents? Actually, it's not that easy, because then you probably have seen that a lot of people would use and go on YouTube, both from the surgeons, or the ones who should be educator, but sometimes are just self-marketing, and also the student or the resident or the surgeon that wants to learn a specific technique would go directly on the YouTube. The problem of YouTube is freedom that is extreme, obviously, as it should be on such a channel, on such a non-educational channel, but definitely we need something more structured. We need educational criteria. We need practice guidelines for reporting educational videos. And this was the object of a consensus, which I also joined some 3 years ago, that wanted to set the skill, not only the skills, but the parameter and domains that should be taken into account before considering a video, an educational video. And that was done also by basically a similar group of experts also for robotic videos. Building up those videos will make video library. There are a lot of video library at the moment around. If you look at, these are only some of them. And as you can see, some of them are generated by companies, and some of them are generated by scientific societies. But what they have in common is that most of them would start as a video library and would become, with time, or would like to aim to become surgical communities. And this is something that is definitely taken also from the social media revolution. So where sharing is actually the key for listening or learning or about something. And here are some examples of the majors of medical devices. This is an example, is the Ssat from Johnson & Johnson, or the touch surgery platform from Medtronic, or another from a smaller UK company, SurgeEase. But they have in common that they store the videos, they divide the videos, they tag the videos, and then with artificial intelligence, you might, for example, look at, you might want to see a specific step, how it is performed by Professor Pietrabissa, by Professor Voté, or by any of the experts here. It's really important when you think that you could get the access. Obviously, there is also a huge challenge with this. It's not only gold, as we might discuss later in the discussion. Anyway, where are we going then? When we digitalize every surgery, every surgical operation, definitely we have a potential geographically independent in training. And this is not only in terms of getting a monodirected indication on how to perform a certain operation, but it can become a bidirectional visual and audio communication between an OR. And this is extremely important because we really believe that now a simulation center and a skill center is not only about simulation and models, but it's also about interconnecting. And this is becoming more and more clear when you get these kind of telestration platforms where you can, when a surgeon, which is more expert into a procedure, can, after the training of another surgeon, can, for example, mentor, instead of being personally in the OR above the shoulder, can be at home and on his or her mobile can just indicate with his or her finger where the surgeon has to go, and basically with no lack of latency, with no latency, thanks to the 5G connection, can basically interact real time. But obviously, what is behind the screen? Because minimal invasive surgery can also complicate the learning process, because the indirect vision, what I mean with indirect vision is that basically when you see an operation performed in open surgery, you see that the surgeon moves the hands on the tissue or moves the instrument on the tissue directly. And so you see the maneuvers, the movement of the surgeon, and directly you also see the effect on the tissue. But when you look at surgical videos, most often in minimal invasive surgery, they lack for the extracorporeal part. So you only see what the first, not what the first operation is doing, but the result of his actions. So this might add a complexity as well. And furthermore, we don't have to forget that at the present state, minimally invasive surgery and minimally invasive teaching lacks for the vast majority, the third dimension, and lacks the important tactile sensation. And obviously there is a disparity between visual and proprioceptive feedback, which are very well known. And as Guido Torzilli just mentioned, it is really true that watching is not enough. So mentoring remains the mainstream of teaching, and there is therefore a need for more and more established surgical curricula. And for minimally invasive surgery, there are, for some procedures especially, a very structured which starts from watching, and even watching videos from the libraries as well, then training on simulator. Probably Professor Pietrabissa will say more about that. And then on-field training, performing the surgery under tutoring, then mentoring, and after mentoring, the surgical coaching, which is something for, as you see, we have done an example recently of that for rectal cancer surgery, but this is something that you would address and offer only to more experienced people. I will just spend a couple of seconds on simulation, because Professor Torzilli already mentioned that we are lucky to have a really good simulation center here. But there are different ways to do simulation. One is the low fidelity simulators, which means that either you have a physical simulator like a box trainer or a cadaver or an animal model, or some tissues, some hybrid simulation system in which you have some tissues integrated into a box or a trainer or something like that, and they have different trainee population as targets, obviously more or less experienced. But also nowadays we have high fidelity simulators in which the virtual reality is the queen, and it can be either completely virtual or hybrid, again, where you combine virtual reality and physical simulator. But it is definitely a huge it's a huge difficulty and cost. I would say at some point also a burden to train, but in Italy specifically, we really need to do that more and more, because we will be lacking, we already are lacking general surgeons, but this will become dramatic in a few years if those projections will not be changed. So surgical societies have to do something. This is what is an example of what we took for colorectal surgery from several societies around the world that are trying to help the subspecialty training, not only in minimal invasive surgery, but in colorectal surgery at all. And there are, for example, there is a very good model of the surgical oncology societies and of the Royal College of Surgeons of England that tried to build up some recognized international and global curricula that can be valid independently from the nation. Does this work? Does a structured training and assessment curriculum for technical skill acquisition in minimally invasive surgery work? There is incredibly a randomized control trial, not big numbers, but still interesting to see that the results show that there is a significantly better performance in the first 4 OR procedures for people, for trainees that were trained by such a structured model. So minimally invasive surgery is a learning opportunity and also can democratize at a certain extent the training, because people are not necessarily going to be obliged to travel in order to get the best of their training. So to conclude, minimally invasive surgery is based on videos, and videos pave the ground for digital surgery. Digital surgery provides new opportunities through video storage, tagging, and sharing. Minimally invasive surgery also presents some new challenges related to the instrument training and specific skills requirement, and definitely with structured training. And training, even if might not be immediately cost effective, it is really essential. And adoption of quality criteria and international global curricula for specific areas with fixed standards are really advisable for a very effective training more and more. Thank you a lot.
Thank you, Antonino. And now we are just a little delay as regard the time, but we have enough time for discussion. As already mentioned by Carlo, we are postpone all the questions at the end of the story. And then please, Carlo, would you like to introduce next?
Thank you, Massimo. It's a great pleasure for me to introduce Matteo Donadon, a young associate professor of surgery in Humanitas University. He will address a very relevant topic. So the relevance of including basic research in the educational process of residents. So we are complicating more and more the scenario. Please, Matteo.
Yes, thank you very much. And thanks to the SSAT for the participation in this webinar. My topic is the surgeon scientist and hobby or a need. This will be the agenda. I will go toward the definition of surgical research, the ideal setting and types of surgical research, who is and what is a surgeon scientist. I will show you a few slides about our idea on surgeon scientist training track, a few slides about our translational program, and I go for the conclusions. So I think it's important to remind us what is a surgical research, which can be considered as the application of the scientific method in surgery, and also the analysis of conventional or innovative ideas related to surgery. And we like to be open and inclusive by using a very large definition to avoid exclusionary limits, as was used by said by Karl Popper. And it's important also to remember us and also to the whole audience, you know, the 4 main rules that are the fundamental of the scientific methods. They include never accept anything as true without sufficient evidence, divide problems into small parts, begin with the simplest and then action to more sophisticated problems step by step, and then make reviews and list every possible details with the aim of leaving nothing out. And speaking about the ideal setting of surgical research, I could say that the ideal setting might be the academic surgical center if the academy is really devoted to inspire young surgeons. However, also peripheral non-academic center might be adequate if both institutions and professionals are research oriented. But again, to be open and inclusive is not the place that defines surgical research. We can consider 3 main types of surgical research. The first one is the clinical research that follow the statement turning clinical problems into research studies. It includes clinical trials, studies on estimated risk and prognosis, studying on diagnostic tests, scoring, staging system, and also computer models and technological improvements. The second type can be basic research, meaning laboratory and experimental studies. This type of research include research that is not necessarily linked to a clinical problems, studies on etiology and pathophysiological studies, mechanism of disease, and in vitro and in vivo models. The third type of surgical research is translational research, which follow the well-known statement from the bedside to the bench and back. It includes basic research applied to a clinical problem. So it's a basic research clinically oriented by using, disease models in vitro or in vivo. It includes also operation made in vivo, diagnostic, prognostic, and therapeutic, the so-called theranostic studies, and the research for biomarkers by using liquid and tissue samples. Coming back to the ideal setting, I can say that the right setting for surgical research is where at least one of these three types of research is conducted, while the ideal setting is where all these three types of research are conducted. Not mentioning the research findings issues means that, as we know, today to conduct important and sophisticated research, we need to get funds from competitive grants. But at this time, I like to stay on a more general level of the speech. So, who or what is the surgeon scientist? If we go inside the definition, we can say that, of course, the clinical and technical skills are imperative for surgeon, but a commitment to study the fundamental of surgical disease is essential for advancing surgery. Surgeons are in the unique position to make a diagnosis and therapy of a disease with direct access to tissues. And surgeons have the unique perspective of a given disease they operate. And we consider the operating room as our laboratory. So a surgeon scientist can be defined as a surgeon interested in applying the scientific method to better treat patients, better understand a surgical disease, better discover novelty that promotes surgery. And, the rationale is that today is impossible to be expert in all aspects of the surgical fields. Subspecialization should be, therefore, associated with the research methodology and the biological insights. Today, we know that the research methodology has become more and more challenging, and most of the research is warranted only through competitive grants. Therefore, it's important to translate our clinical problems into laboratory experiments. And even if not of the lab experiments are for surgeons, we can say that surgeons can run lab experiments once they become familiar with the lab environment. We know indeed that surgeons are probably the most flexible and adaptable people among doctors. At this time, I like to show these slides because to me it's interesting, even if on a general level of knowledge, to look at those surgeons who won the Nobel Prize. You can see from this table that so far 9 surgeons won the Nobel Prize, from Coker 1901 to Murray 1990. What is interesting to me is that probably most of these surgeons, in a certain way, they had a very deep knowledge of their specific area of interest, also from the biological point of view, which is a very important point to reach an excellent result. And here in Humanitas, we are trying to set up the so-called surgeon scientist training track, which is a program that we are running for our residents and young fellows, which include some activities. Some of them are listed in the slides, such as how to write a manuscript, how to write a grant for fundraising, some courses about ethics in clinic and ethics in publishing, how to design a study, how to work in the lab, being a surgeon, and so on. And among these, there is, of course, an important chapter that is the mentorship program, the mentor-mentee relationship, which is as I said before, by Professor Spinelli and Professor Tozzilli, it's really important to make a good point to our young residents. And in this sense, I'm lucky because today I have here two of my mentors, Professor Tozzilli and Professor Botte. So one could ask, which is the end point of this program? I can say that, of course, the education and training of young surgeons, meaning residents and fellows, but also continuing education for all the professionals, and also talent scouting for residents, because we can select the best for our PhD programs and also for faculty positions. And coming back a little bit on our translational activity, we run our lab by following the statement that translational research is a method to answer to a clinical question. It's the way to integrate the basic knowledge to address the clinical problem. And being doctors, being surgeons, we know that human beings are different from mice, so we like to work on human tissue rather than on animals. And in this sense, we were able to establish here our lab unit, which is a multidisciplinary team made by different principal investigators that while they are working on their specific independent funds, they work together with the aim to study liver disease and to make translational research. And what we do, we study mainly our three types of disease: hepatocellular carcinoma, cholangiocellular carcinoma, and colorectal liver mets. We get sample during operation on tumor tissue, peritumoral tissue, and normal liver. And by using different methodology, different technology, basically, we look at a prognostic signature, meaning new markers, new with the focus to refine the selection process and the prognosis of the patient we operate. With the aim to stay anyway humble, but to give some tips and tricks about translational lab, I think it's important to say that it's really important to collaborate, to organize ideas and the workforce, and having a team with different expertise. It's really important. Of course, it's important to have the volume of human cases and the guest support from the grant office. It's also important to get in touch with established researchers. In terms of a grant application, it's important to do spontaneous search on the web, because there are many more grants that in general is out. And of course, it's important to do not give up at the first failed application. So I go to the conclusion. The title of the presentation was The Surgeon Scientist and Hobby or a Need. Of course, it's a need. It's a need for our young resident fellow and for all of us, because where there is research, also the care and the cure of our patient in general is better. Thank you very much for your attention.
Thank you very much, Matteo, for this excellent overview on research programs in inside the residence program. We will leave the question later, so please, Massimo, would you like to introduce?
But anyway, now I recognize that I was wrong. Since we are just a little delayed, I would like to.
I suppose it was a hobby, Matteo, but since we are. Okay, so I'm introducing Professor Andrea Pietrabissa, who is full professor of surgery in Pavia, who is a very beautiful city nearby Milan. But Andrea is also one of the most leading representative of the Pisa School. And as you know, Pisa has got a lot of experience in simulation and robot surgery. And Andrea is giving us a new perspective about the role of simulation and new technologies. I think that Andrea is a beautiful speaker for this topic as well as for the other. Please, Andrea.
Well, thank you, Massimo, for your kind words of introduction. Let me say in the first place that it's a pleasure to join this panel today, and I feel privileged for the opportunity to contribute to this very...
Matteo, I think that you should stop to share your screen.
Okay, there we are. So it's a privilege to be able to contribute to the topic of education. And I'm sure that everybody would agree that the process of educating junior surgical trainees has to be the combination of multiple different types of input that ranges from web-based education to hands-on training in the OR, mentoring, tutoring, and simulating the clinical environment with commercial available simulators, as many of us are now being equipped with within our academic community. So I will not cover something which is already well known to most of us, and instead I would like to focus my talk on something which is relatively new, and that is the use of the 3D printing technology for the purpose of educating and training both medical students and residents in surgery. Now, if you look at the bottom of this slide, you can get a figure of where Pavia, where I'm based, is. As Massimo Falconi was mentioning before, it's about half an hour drive south to the city of Milan, that might be more familiar to you. And talking about ages of universities, you heard that the Humanitas University is brand new one. At the opposite, we were established in 1361, so I think old one. This video shows our clinical laboratory for 3D printing, which is named 3D for Med. The lab was created as an hospital facility. So it's not a toy for surgeons, but it's something made available to every clinician within our hospital. And that is because the 3D technology, 3D printing technology, has a number of potential applications that go far beyond the need of surgeons. The laboratory has personnel, dedicated personnel. We have 3 biomedical engineers working full-time in the lab, and a wide range of industrial quality 3D printers, from chalk printers to photodynamic resins printers, metallic ones, and so on. We also have a strong partnership with the major player in the 3D printer industry. And the basic idea of using these models derive from the very past. And these are some wax sculpture that are kept within our museum for the history of medicine at the University of Pavia. They were made of bee wax in the past. And so we share the same vision that having a 3D model of the target anatomy in your hands is probably better than any other virtual reconstruction or 3D vision that we are used to. The video that just ran is a skull that was made because of an orbit defect after a trauma, and we were able, with our maxillofacial surgeons, to reconstruct the placement of the orbit using this model to manufacture the specific piece that was lost. So the initial approach for the use of this technology was basically for the purpose of planning, so pre-operative planning in surgery, but not just in surgery. Also, our interventional cardiologists or radiologists would like to have those models in their hands the day before to better decide on the best approach to treat those patients. The video that just ran is a tumor of the lung with the vascularization of the hilum of the lung. And in fact, it worked that way. I think I have more examples of this technology. Again, this is a printout of the superior mesenteric vessels, artery and vein, that was meant for a total central mesocolic excision, which is now fashion in some patients with right side colon cancer, as you might know. And the extreme anatomical variability between one patient and another makes useful to have this model in your hand throughout the surgery, and you can decide whether at which stage are you throughout the operation. So again, these rigid models were suitable for preoperative and sometimes intraoperative planning and, let's say, navigation at the same time. But the breakthrough came with the availability of a new category of 3D printers capable of manufacturing 3D objects deformable, so made of, let's say, plastic material that sometimes resemble silicone. So it is deformable. You can cut, you can suture, you can expose to some extent in a way which is similar to real surgery. And this technology allowed to shift from just preoperative planning to simulating an operation. This technology, which is derived again from a patient's CT data set, is not suitable for everything, but it applies very successfully to some selected issues within the field of general and vascular surgery. So here is an example again. You can see a left kidney with the aorta, and this kidney has two arteries and then the vein. And the stiffness of the kidney itself, as well as of those vessels, is made in such a way that it tends to replicate the exact texture and consistency of the organs and tissue this model was derived from. This specific model was initially used to simulate the laparoscopic kidney donation for transplantation, and it was used to reconstruct in bench surgery those two arteries and decide which one was the best type of reconstruction. But moving from that, we use the model also for different patient-specific settings. In this particular case, there's an aneurysm of the splenic artery. This is the 3D reconstruction derived from the CT scan. You can see the aneurysm close to the hilum of the spleen. And this is the 3D printed model, which is approached robotically in vitro. And on a side, this is the real operation done with the help of the Da Vinci robot. So the main splenic artery is divided proximally and distally to the aneurysm, and then the two ends of the artery are anastomosed with interrupted stitches in the simulated environment and in the real one. So you get the chance here on a very particular clinical setting, not for everything, but you get the chance to train yourself or your residents, if you wish, on a specific operation that is going to happen the next day. So it's a patient-specific training, something which is available only through the use of 3D printing technology or virtual reality technology. But the issue here is that it is patient-specific. In the same way, you can replicate whatever technical challenge you might face during real surgery. Then the aneurysm is dissected off the vein, which is located posteriorly. And again, the same would be done in theater. And that's the final step of this procedure. The aneurysm has been fenestrated to make sure there are no feeding vessels left. And then it's removed from the back. So let me move ahead. Okay, and then we decided to set up a simulation platform for kidney transplantation. The underlying idea is that kidney transplantation is not very much suitable as a training setting in the real clinical situation because of the time constraints of this procedure in general. So it was ideal training in transplantation in a ideal setting, which is off-site, which is in vitro, like the one shown here. And so we replicate the main components of the anatomical field, the iliac vessels, the bladder, the psoas muscles, the bones, and then the external skin and abdominal wall of the patient. Then we use this simulated environment directly in a simulated OR in such a way that the junior trainees is asked to overcome not just technical challenges, but also is positioned as a team leader within an operation of kidney transplantation. So all the 3 anastomosis are done in a relatively real environment, like the one shown in this final video. So she has to decide on how to make the skin incision, place retractors, and expose by displacing the peritoneum sac, and then exposing the area, trimming the graft by cutting the excess length of the vein, and then simulating the 3 anastomosis. And again, it is not just a technical challenge by itself, which is quite much the same as in the real setting, but also you have to deal with your own first assistant and all the other people that form the team. And that is an extra training in terms of team working for our junior trainees. And that was very much appreciated by everybody and has been the subject of a recent publication in surgical endoscopy on this topic. So this is just an example on how this relatively new technology of 3D printing can contribute to the multi-input complex growth in the path of our junior trainees. And I think the contribution can be relevant as long as we are able to reproduce different settings, not just kidney transplantation, but the same can be done for TA-TME. We've been discussing this topic with Antonino Spinelli in the past, or liver surgery. Many things can be can get married with this technology and produce interesting outcomes. So coming to an end, I'm pretty sure that the use of 3D printed technology is a very good way to deliver anatomical information from the radiology department to the final user, and nowadays also offer an attractive opportunity for patient-specific surgical simulation. Of course, there are drawbacks that we must be able to address in the future. Cost, time it requires. It is currently limited to what you can actually precisely see with the contrast enhanced CT scan. And of course, you need a dedicated team. And I got the fortune to have in my university a team of engineers who are passionate with the 3D technology, and so we managed to work together very successfully. So thank you very much, and I will be glad to answer any question on this topic.
Andrea, very impressive lecture and very impressive technology. I would like just to ask briefly, how do you know if outside Pavia there are other facilities around Italy in this specific field?
Now, our laboratory, again, the name is 3D4Med, has created an international network of similar facilities around the world. There are not that many, to be honest, at least to our knowledge. We are now collaborating with similar laboratories in Japan, in South Korea. There's another one in Taiwan. We are also working with the Imperial College in London, and that's about it at the moment. But
no other places in Italy.
Well, in Italy, no, not to the extent, not as a facility. Of course, there have been attempts at producing 3D printed organs for the purpose of planning dedicated procedures here and then scattered throughout the country, but that's not the same thing. I'm talking about an hospital facility or an academic facility, if you wish, which is available every day in the year and not just occasionally because you have a special case to deal with.
Okay, thank you very much. Carlo, up to you.
Thank you very much, Massimo. It's now a great pleasure for me to introduce a young and brilliant surgeon and researcher, Gaia Spolverato. She trained at the University of Padua, the university where I come from, and then she trained in the US too. I think she is really in the best position to address the topic of careers for women in surgery, problems and perspectives. Please, Gaia.
Thank you very much. You should see my screen. It's a great pleasure for me to be here today with the giants to talk about career for women surgeons, problem and perspectives. I have a conflict of interest. I'm a woman surgeon, and I truly believe that in the future, there will be no female leaders. Will we just consider leaders or not? So are we different anyhow? This nice study on 132 students, fourth-year med student and first-year residents, showed that gender displayed no effect on fundamentals of laparoscopic surgery training outcomes, except for the fact that men tend to be a little bit better to place PEG and to do intercorporeal knot tying. Women tend to be better in the long term, and when they continue to train, they perform better. So what is a drawback? Maybe women tend to underestimate themselves, as shown in this nice paper on female urologists and trainees, where women shown to underestimate their surgical skills on self-assessment. This is probably because of the fact that we have been buried by prejudices and stereotypes that delayed and reduced the entry of women into the practice of surgery. But even if we are increasing over time, I don't really think that it's just a matter of time. Because when we look at the leadership position, there are still very few women. If you look at the Italian College of Full Professor of Surgery, that we all Italian know, out of 111 members, just 3 of them are women. So we have been discussing about the pipeline problem. We do think that this is described as the fact that fewer women work in academic position than would be expected. And we don't really think that it's just a matter of increasing the denominator. Because there is this invisible but impenetrable barrier between women and the executive suite called the glass ceiling, preventing them from reaching the highest level of the business world, regardless of their accomplishment and merits, and not only in the surgical field. Because if you look at these 2 papers, one published in Annals of Surgery in 2011 that shows that among women who enter med school, very few of them become dean or achieve a leadership position compared to the rate of men. This is also called the pipeline phenomenon. And as you can see here, as depicted as a pipeline from 47.6% of med students to 9.8% of full professor. This is a very nice paper published in the New England Journal of Medicine by the American College of Surgeons colleague on 7,409 residents. 32% of them described gender-based discrimination. 30% of them experienced verbal and physical abuse. 10% of them experienced sexual harassment. And among women, 65% of them experienced gender discrimination, and 20% of them experienced sexual harassment. 38% had symptoms of overall burnout. Most of them were women, and 4.5% of them had suicidal thought. And again, as you can see from this graph, unfortunately, most of them are female. We perform our national survey addressing gender-related challenges in Italy. We reached 1,833 Italian female surgeons who completed the survey. 62% of them think that they are treated differently because they are female. Microaggression, sexual harassment are common, but rarely reported. 1/3 of them are satisfied by their work-life balance, and the majority of them take care of housekeeping and childcare duties. But beside all this, 84% would choose surgery again. And if you look at this graph, the sources of dissatisfaction at work were mostly lack of work-life balance, lack of surgical training, lack of mentorship. But I would say it's just not for female. This is, I would say, for all the young faculty and residents. Because one of the limitations of our survey that was just sent to female surgeons, but we're going to work on that. So what can we do better? You have been talking about mentorship. I embrace your feeling about mentorship. And I truly think that strong mentorship program should be run in our country, following the US steps. We, as the Women's Surgery Italia, we are starting a program very soon, and I wish you can be our mentors. We also should start thinking about the role of same-sex mentor, because for some reason, same-sex mentor have similar thoughts about career and personal life, and also about managing the time of the daytime. And the mentor should allow the fellow, the mentee, to be early involved in organization, and should work together to find the path. I do think that technology, as you all said, is really important for training and for filling the gap. But you have also to understand that most of the technology that we are using right now are set, are tested mainly on male surgeons, as declared by the Women in Health Europe and Women in Health Italy. So we should think about some biases when we approach new technologies. I do think that telementorship and telerobotic surgery and assisting will help also women surgeons, not only all the residents. Of course, overcoming physical and strength barrier, possibly helping to perform surgery during pregnancy. I'm not sure that you all know that in Italy, for example, you cannot perform any type of surgery. You cannot enter an OR while you are pregnant, and you cannot work for the 4 months after delivery. Remote training would help. And of course, for those who have lack of self-esteem, the possibility to objectivate their performance would be helpful. Another aspect that I think that is really crucial here is the involvement, the engagement of men. Using Emma Watson words, men, I would like to take this opportunity to extend your formal invitation. Gender equality is your issue too. We need to work on fatherhood. We need to have men engaged in the personal and family duties. We know to work on maternity leave law, mostly in some countries. We need to have childcare facilities and services within the hospital. Otherwise, we cannot be 120% engaged to our work as we would like. We need men involved in order to reduce the invisible workload. We have to change our mentality, and we have to do it together. Because I truly think that it's not just a matter of being a good surgeon or a good mom or a good wife or a good whatever. I do think that if I'm a good mother, I'm also a very good surgeon. Many of these opportunities and perspectives have been summarized in this nice paper published recently in JAMA Surgery. And once again, they stress the need of research focused on this topic, on the involvement of societies, of institutions, of creating a work environment where women can express themselves, where we can definitely work on the other 50% of the human capital. And I do think that association works. This is why in 2015, I co-founded Women in Surgery Italia, that helped to favor a healthy work environment, encourage leadership, promote mentorship and surgical education, create a network of Italian women surgeons in all specialties. And I think that we work better together. We work better if we are together, and we work better if we have men on our side. But beside that, I don't think that we don't nearly enough science research to find a cure for drugs. So I truly thank yourself. I thank you, because I do think that this is just a starting point for us to work together in SSAT for a better work and a better workplace and a more inclusive type of surgery. Thank you.
Thank you very much, Gaia, for your excellent presentation. And it opens a great perspective for the future, but we have a long way to go, I think, together. So, Massimo, if you agree, we can open the discussion. I would like, if you agree, to invite both Sharon and Marco to give us an opinion on this webinar.
Yes, I completely agree with you. I was really curious to listen to what is the impression that we try to give in this seminar about the situation in Italy. Obviously, as already mentioned by Marco, what we know is that the presenters are coming from one of the leading institutions in Italy as regard training and trainees. Probably it is not, I would say, nationwide the picture of what we are. However, please, Sharon, according to the gender, you are the first.
Thank you very much. I will say this is really a fascinating webinar, and I appreciate everyone's input. It's just so interesting for someone who's coming from a completely different training environment to really understand the challenges. And I think I will again thank Dr. Voté for helping us sort of bridge this lack of understanding about the differences between these systems. And I think once we have better understanding of that, we might be able to have some mutual collaborations that allow us to move both of our systems forward, understanding the challenges that everyone has faced and how they're working to overcome those challenges. So I would just congratulate the group on a really fantastic webinar.
Marco.
I agree with Sharon. Outstanding presentations. Two comments. One, Massimo, I think you're right. The San Raffaele Humanitas are wonderful institutions. If I had the opportunity to train in one of them, I don't think I would have gone to the United States. But I want to focus on the presentation of Dr. Spolverata. That was outstanding. And I have a disclosure. Sharon knows my wife is a vascular surgeon. She's now the dean of the UVA Medical School, and she's the editor-in-chief of JAMA Surgery. So I've lived what Dr. Spolverato says every night when my wife comes home, and she mentioned all the challenges that people that she knows and other people have had, especially women. I think, as Massimo was saying, we have a long way to go. Even in the United States, I mean, in main institution, there is, Sharon, please confirm it, there is a difference in compensation between men and women that do exactly the same job. And as Dr. Spolverato mentioned, there are fewer women in leadership position. I think right now, there are about 160 programs in the United States, and there are no more than 18 women that are chair of the departments. So it's a common problem. And I'm very glad that Dr. Spolverato was given the opportunity to mention the problems. Now, regarding work-life balance, let me make a comment. There is nothing magic about it. And I always remember the words of Welch, who was the CEO of General Electric. Work-life balance doesn't exist. In reality, you make choices and then you live with the choices you make. So, for instance, if you marry somebody who doesn't do anything at home, the mother will have the role of surgeons and also taking care of the house, taking care of the children. Regarding pregnancy, I can tell you a story. When I was at UCSF, the chairman was Nancy Asher, transplant surgeon. She did a liver transplant the day before she delivered, and she did the liver transplant the day after she delivered. Beautiful cases. So that's all I can tell you. Again, thank you very much to all the speakers. I thought that this was a fantastic webinar. And I thank you, Dr. Voté and Dr. Torzilli and everybody else for organizing it.
Sorry, there is a Guido who has raised his hand. Please, Guido. And I would like also to invite Gaia to give the answer. In the question and answer, there is a question: how can improve the importance of sponsorship to help the careers of outstanding women in surgery? Gaia, if you can answer directly on the screen, and please, Guido.
Let Gaia answering with, directly talking, I guess. Will be easier than writing if she wants. So
it's the sponsorship thing is it's a very crucial thing, because we tend to ask less for money, and again we tend to underestimate ourselves. So I truly think that when we look at grant application, when we look at position application, we should consider the unconscious bias and the conscious bias, and we should account for them. I don't know. I know that, for example, at UCSF, they started to use like a score or something to help women with the same title, with the same achieving the same goal to get earlier a promotion. I think this is something we should start thinking about even here. I now work with the Dean of the University of Padua on this topic, and we're having a lot of problem because the law is quite strict on this. But I think that a sponsorship need to be really helped, because we tend to have less money, we tend to be less often PI in project, and for this reason we are having a hard time to create our group and then to grow as surgeon scientists, for example.
Guido, very briefly, and thereafter Andrea, and then we are closing thanks to Professor Votini, the webinar. Please, Guido.
And I would just to comment briefly. Of course, I agree with Marco Patti that our system is not the system in our country. But is something, because before there were no examples. Now we have, and they are successful. Then we would like to do a positive COVID effect. That means infecting the population for something good, rather than as COVID is doing, unfortunately, all over the world. And even the fact that has been possible is a big change, because there was a door that has been opened, probably inadvertently, but has been opened. So I think that we have to endure and, giving back to our country what they didn't give to us, because the ideas that promoting all this activity comes from experience abroad, where every one of us has done, and someone has to come back, as I did, and I wanted to translate something better, what I experienced dramatically, as you said, in my initial experience in my career, even in Milano. Just this one. Thank you.
Andrea, please.
Yes, I just wanted to contribute with a comment on the issue of diversity and inclusion. I think surgical societies, and perhaps even SSAT, might provide structured leadership development programs aimed to prepare our junior members for professional society leadership, team building, business strategy. And such a program should have a strong commitment to diversity, equity, and inclusion efforts that might provide systematic training in diversity awareness. Unintentional and unconscious biases recognition training can help promote a culture that recognizes the value of gender, racial, and cognitive diversity. And again, we are not doing enough, not simply within our training programs, but at a surgical society level. Thank you.
Professor Watney, I think that is up to you to make the conclusion of this beautiful webinar, where I learned personally a lot of things, and I realized that probably Humanitas is better than San Raffaele. Please, Professor Watney.
We leave the competition up to you. You know, it's like between Hopkins and Harvard. So you're at the top, so don't feel bad about it. Look, I really am delighted to have been, leading this group towards a new chapter. I think it's the first chapter of many chapters for Italy, and please continue to join us. The comments and the presentations were all great. Regarding the presence of women and role of women in surgery, I couldn't agree more with you, Gaia. And I think we can certainly talk about, we have a committee, diversity and inclusion committee at SSAT, and we've done a lot of work. But I think the work should start in your own backyard. And I would say that, in fact, women have a lot of qualities, and we recognize them every day when we operate, when I operate, when I am with a fellow, with a woman. I feel really enriched at the end of the month for all the qualities that are not recognized. Now it's going to be an important self-conscious realization for men in surgery that being good is not necessarily by occupying all the space and trying to be first and trying to be there all the time. We were trained to work 100 hours per week, and I started in a pyramided program. We started in the US, and I would say to Marco, it was good, but it was not all good for me coming from Switzerland when I saw that. We started 10, we finished 4. And we are just like trained, and it becomes a trained reflex to occupy. So please, man, instead of having 10 things on your to-do list, keep 6 and leave space to others. I think it's a responsibility, and it's parts of selflessness. Selflessness for man is something that needs to be learned. Thank you very much. I hope this was not too deep, but I thank you, Guido. Thank you, all the moderators, Professor Falconi, Professor Castoro, dear Marco, grazie mille. And Sharon, thank you very much. And thank you, all the speakers.
Thank you, Nick.
See you soon.